when Sam invited me to come and give this talk, I didn't realize it was a setup and that I would be sent in as the earnest cleaner to follow Bruce. Yeah, it was a bit of a surprise to have to follow that amazing act. I just want to reach for the clicker and come to my disclosure slide. I don't have any conflict of interest to report other than that I do read medical journals and occasionally pay attention to what they say. So I do have a bit of a slightly different, perhaps more earnest perspective. And I have not been invited out to the conflict of interest prom, but if anybody wants to offer me a date, I would consider it. So what we're going to talk about today is we're just going to really briefly look at MRSA and look at it in the framework of a few stories. We're going to look at the difference between hospital-acquired and community-acquired MRSA and what the heck it all means. A little bit of an approach to some evidence behind skin and soft tissue infections, some issues around barrier precautions and whether I think it's voodoo or whether there might actually be some science. And we're going to talk about sepsis and MRSA. So the background here, I actually think this is quite fascinating. MRSA passes resistance back and forth. These staphylococcal organisms create little genetic packets called cassettes. And the SCC stands for staphylococcal cassette. This is how they communicate and give resistance back and forth. So hospital-acquired MRSA has actually been around since early 1960s and been slowly developing in hospital environments. The MRSAs are getting together. They're passing these cassettes back and forth, and the resistance profiles in individual centers is growing and growing. And they have particular types of complex cassettes that they pass around. Cassettes 1, 2, and 3 are actually quite large and unwieldy, the classic hospital-acquired MRSA cassette. And so they're a little bit more difficult, and it takes a bit more time for these staphylococcal organisms to pass them back and forth. In the late 1990s, we suddenly started seeing these different kinds of MRSA organisms. And they had different cassettes that were actually much smaller and much more simple and very easy for these organisms to pass back and forth. And so what happened was we had this steadily growing epidemic of hospital-acquired MRSA, and all of a sudden we had this explosion of community-acquired MRSA that showed up within pretty much the last decade. The other thing that community-acquired MRSA has that's a little bit different is this thing called PVL toxin, which is Pantin Valentine leukocidin. It's a long, complicated name that basically means it's got a toxin attached to it that makes it more likely to produce pus or pus in infections. So it's a necrosis toxin and a virulence factor. So what does this really mean? What it means is that, as we know, hospital-acquired MRSA is much more resistant to a wide variety of antibiotics. And basically, you only have vancomycin, daptomycin, rifampin, linezolid, and occasionally clindamycin to treat it. Everything else doesn't work. Community-acquired MRSA has, fortunately, a much broader profile. So we're able to use things like tetracycline and Septra and clindamycin fairly regularly to treat these organisms, which is a nicer counterpoint to this exploding epidemic of community-acquired MRSA that we're seeing. So what do we take from this? Well, both of them are bad players. They both cause bad infections, and they do have a classic profile, although you cannot always tell. In fact, I would argue that you can rarely tell what you're dealing with when it rolls in the door. But there is a classic prototype infection. And hospital-acquired MRSA usually causes a wound infection or a device infection in a patient who's been exposed or hospitalized. That's the classic. We don't see it all the time, and generally speaking, there are many more invasive infections that roll out from that. The community-acquired MRSA classic is an abscess, a skin abscess. And the really classic part of it is that it's a focused collection of pus with a central area of necrosis. And people will talk about how it looks like a spider bite. In fact, that's one of the only things that can help you decide if something is CA MRSA off the bat. Is if people tell you they've been bitten by a spider, it's apparently 5 or 6 times more likely that they actually have community-acquired MRSA. So that's one of those interesting things that we're seeing in the outbreak. So both hospital-acquired and community-acquired MRSA are in evolution, and they're very center and regionally dependent, the prevalence. In the States, more than half of MRSA isolates, all staphylococcal isolates, are some form of MRSA. So in the States, this is a huge, huge problem. And in some urban centers in Canada, it's starting to be a huge problem to that magnitude as well. And Vancouver and Toronto, we've published some data in CGEM that shows that actually Vancouver and Toronto are certainly seeing resistance rates that are approaching that of major US centers. Some of the other community centers, it's not really clear how much we have. But I guarantee you that it's going to be climbing and changing. And I think one of the things you should take away from my more earnest talk